Thank you very much. Great talk. We'll take questions here. I'll also ask definitely to come back up to the front, and we'll kind of just let this flow into the discussion period. So, questions?
We have a question from Bruce McEwen online.
Okay, great.
Can you read it, Andrew?
Bruce McEwen is actually unmuted. So
Bruce?
Bruce, can you hear us?
Hi, everybody. I really enjoyed the talks this morning, and Dr. Manley, the question I wondered about the intervention of the SAF, Safe American Family Study, building bonds with an adolescent and his or her caregiver's parents, and looking at ways of fighting bullying, racial discrimination, with outcomes that 10 to 15 years later appeared to preserve some aspects of brain function, brain volume, less depression, and also less type 2 diabetes, or at least insulin resistance. I wonder if you could comment on that and how that might be related to some of the things you were talking about.
You know, it's the first time I've heard about the study. Thank you very much for bringing my attention to it. This is the kind of intervention that I think, I'm referring to in my last slide as interventions that we should follow up on and understand through, the impacts throughout the life course. You mentioned something about diabetes and metabolic syndrome. I think one of the ideas here is that inflammation is one of the pathways that especially in Alzheimer's disease, that's been to date relatively underappreciated. There's been a really amyloid-centric focus. And so I find it intriguing that was one of the impacts, one of the health impacts of the intervention.
Well, I totally agree. And in fact, yesterday, she's not there today, Natalie Razgon talked about insulin resistance and the 3Ds, diabetes, depression, and dementia. It's definitely a pathway towards dementia. And in as much as people develop these things early in life, often partly exacerbated by early life abuse, neglect, poverty, and so on, it's going to bias the system. And those people with certain genotypes will then follow this particular path. So I totally agree about the emphasis on inflammation, also overactivity of glutamatergic systems in the brain, which drive the amyloid beta story, and attempts to intervene early, as in the SAF study. And I'll be happy to pass on the 2 key papers on this. I think it's right on the mark of what you were pointing us towards.
Thanks.
Hi, Jen. Liz Nielsen here. Great talk.
Hi, Liz.
You were talking about the need for these life course studies, and you have a lot of experience working both with studies that have prospective data across the full life course, as well as studies focused in older age. My question really is, how do we build the infrastructure for tackling the kinds of questions that you are posing to us? Interested in your perspectives on the value of adding some retrospective measures to studies that focused in older age, of the kind of social exposome variables that you highlighted, as well as how can we strategically get earlier life course studies to incorporate the types of measures that you're talking about so that they'll be valuable for long-term studies of aging and brain health. Thanks.
I'm really glad you asked me really easy questions. So I think what I'll answer with respect to some of the retrospective measures that we can add, I can't emphasize enough the value of the every place you've ever lived question in older adults. We have been able to look at that, not just with respect to childhood exposures and some of the administrative measures in education, which I think have a strong impact on trajectory. But other groups are using those data that have been geocoded for various exposures, walkability, green space, businesses, crime, you name it, all the sort of, explosion now of geocoded information. There are people looking at individual schools and their policing policy and punishment, punishment policies in schools, and how that may relate to stress and outcomes in children. Retrospectively, if we know which schools people attended and what school districts, we can match some of the policies to these later life outcomes. So that's part one, which is that collecting location data retrospectively has been really useful. The other piece that you asked was about what can we tell early life studies, or how can we impress on studies of early life what we need now for later life research. That's a harder one for me. I think, I guess the one thing I would say is cognitive function, because we really want to understand. What the different. If we were to intervene, what would the real impact be? And critical for that is that people start off at age 65 at an intercept. That intercept is strongly related to two things: we know this, their cognition, their young life cognition at age 10 or at age 11, and their family history, but also their exposures after that age. And I think that a lot of researchers on ADRD are kind of obsessed with slope and sort of distinguishing the trajectories with respect to slope over time, and that's related to hippocampal volume, that's related to maybe diabetes, that's related to some of these biomarkers. But I think the biggest impact we can have to maintain brain health is on that intercept that we enter older age with. And that's why these early life studies are so critical. And in order to determine what the impact of some of our interventions would be, we need measures of cognition earlier in life. So, I've been looking a little bit at the Ad Health study, and as a neuropsychologist, it's very frustrating that the cognitive measures are not better. And I know that it probably took a lot to get cognition in there to the extent that it was, but I think collaboration with people who are studying cognitive function later in life would have been fabulous.
Great, thank you very much. So we're just going to continue on the discussion here, and kind of we're a little bit behind. We'll take probably 5 minutes of just kind of going over again some of the general themes that we came here to discuss. I mean, one of the things that I wanted to just actually follow up, with the discussion we just had on disparities is, again, thinking about, when we talk about brain health, what are we what are we specifically trying to describe? I mean, I think in this case, it's nice because we have some measurable units with regard to brain pathology, talking about cognition, but what else? Like one of the things that I actually was we talked about yesterday that was related to this disparities talk right now was describing some of the disparities in how folks describe their quality of life, or how stress is kind of reflected in various types of outcomes depending on what population that we're describing. So, I mean, does anybody have any further ideas about the outcomes or the things that we should be measuring with regard to brain health and kind of what that means? Deanna?
Look at my face.
Yes.
Well, I just have to say I really agree with Jennifer's perspective on this, because I think part of the challenge is, there's two ways you could think about brain health, right? You could think about it as sort of the accumulated reserve that you're bringing to the table, right? That sort of sets that intercept as to where you start from. And then there's the sort of the degree to which you are impacted by adversities that happen, right? Whether that be stress, whether that be illness, whether it be, the occurrence of Alzheimer's disease, but those are likely to be highly related, right? And they're very difficult to tease apart unless you start kind of early on. So, in my Pollyanna days, right, I'm like her, where I want measures starting at birth. Yeah. I want them starting in utero, right, to really be tracking, like, what is setting the stage for what, where, right? Because, Jennifer's talking about things happening in childhood. I think some of these things, even the social determinants, are being set even in utero, right? Like the exposome that the child has as mom is exposed to stress, racism, poverty, all these sorts of things. And that may also be setting up a pro-inflammatory phenotype very early in life that's having these impacts. So,
yeah, I think that's critically important. I mean, I think you can see it in how we're in essence forced to do our research, where we have, you could see that Jen in her talk I think maybe 3 or 4 times she was describing her frustration of where she had to start the study, where that she didn't have the information before, and so then the question is, well, how do you people, you want to have data in utero and then follow them until they're, 85, right? You want that data so you can really try to understand. So then the question is, everybody wants that, but then in the absence of being able to do that, like now, how do you start,
So, but could we maybe think about, okay, so I don't think I'm going to live to 150, so you never know, right? But if we could think about chaining back, right? So if we have, studies that started at X age, and we know that this predictor already at 40 was associated with this outcome, and then we say, okay, now we know that this predictor at 20 tells us something about where that person was at 40, and we can work it back, we might not, maybe this is Pollyanna, we might not have to wait 110 years to know the full answer. But if we can be thinking about sort of intermediate outcomes that we already know predict things, right? We could be starting to go back and say, do we have evidence that there are these things that are starting even earlier that are going to set the stage for this outcome that we already know predicts at 20 for something later?
That's right.
Yeah. No, I really like what you're saying, Deanna, and I think that means explicitly that studies of, you don't need to convince people like Liz Nielsen about this, but I think there is there might be a value of being very explicit that when we talk about aging brain health, which is where I think people are at higher risk for having decline, and becoming part of this disparities wave that I think has the greatest burden, is that those those trajectories start much earlier in life than when they have their greatest impact on function and on, I think, burden and cost to society. So in other words, we're talking about earlier life studies and earlier life research that needs to take place. And the other thing I was going to say about what do we do if we're talking about a whole life course, how do we actually measure it, is that maybe we should consider the idea of triangulation, that we have a number of studies that are focusing on different time periods during the life course, and that we may be able to link those in some way, that they may not have the same cognitive measures, they may not have the same, be focused on the same exact outcomes, but there may be ways of linking and triangulating so that we can, begin to explore, and this wouldn't be definitive, but we can begin to explore some potential targets and also critical periods across the life course.
Yeah, I think that's right, and also thinking, you got to have these ideas kind of in mind as you're prospectively trying to coordinate and design new studies and new research. It's really important that this context is brought to bear.
One thought, just following up on that, in terms of chaining back and linking these data resources, it seems like there needs to be actual investment in doing that and harmonizing those. So if you have different outcomes and different measures across different large-scale, expensive studies, a relatively small, cheap study that harmonized those measures and were able to form like a dictionary across them so you could link them in different populations of interest, seems like it would be a great way to get an additional return on that investment.
That's exactly right.
I would also say the other issue, which is a sad one, is there's so little social mobility in our country that it's unfortunately relatively unlikely, if a child is growing up with a certain set of adversities, that they're going to magically switch to a whole different, set of affordances. And so I think this is, again, a reason to think about things starting earlier, because if someone is 40 years old and is currently living, I live in St. Louis, one of the cities with the worst racial disparities, but, at 40, if you're living in a less well-resourced area and so on, and you grew up in St. Louis, it's highly likely that you grew up in a similar type of area, right? There wasn't a lot of social mobility, suggesting that it's not that those social exposomes just started when people got into their 20s and 40s, that they likely, at least in some places in our country, have been there from very early on. It might be different in other countries where there's more social mobility and more likelihood that someone grew up with less exposure and then drifted into an area with more, into a phase of life with more exposure, but that just doesn't happen that often in the U.S.
All right, so I think it's a really, really nice discussion. I think we'll take a break. We're about 10 minutes behind, so I'd say we'll take a 10-minute break and be back here to start the next session in about 10:02.